Hello, I'm a medical oncologist, Christopher Sweeney from Dana-Farber Cancer Institute, and here in São Paulo at a Uro-Oncology conference. And I've been asked to talk about metastatic prostate cancer. And the question is, what drug and when, and from hormone-sensitive to castration-resistant disease? What I would first of all like to say is that when a patient presents to a doctor, we should see if they are fit for chemotherapy, and we should also see how much cancer they have so we can work out what the treatment options are for them. For the patient with metastatic hormone-sensitive disease and a large burden of cancer on their scans, the treatment options are docetaxel if they're chemo-fit, and abiraterone per the Latitude and the Stampede studies. I think docetaxel and abiraterone are as effective as each other. They just have different risks and benefits. And abiraterone can be given to patients who are not fit for chemotherapy. Chemotherapy with docetaxel has some side effects, and however, it is cheaper and it is done in 18 weeks. So it has some ups and downs, and we need to counsel patients on whether they are a candidate for it or not. I don't think it's either or. The goal is to get both treatment into the patient. So it could be abiraterone followed by docetaxel when castration-resistant disease emerges, or it could be docetaxel followed by abiraterone. So it's all about trying to get as many treatments in, and one reason to maybe give docetaxel soon and early is they are probably the fittest they are when they start the hormonal therapy for the first time, and this may be when they can tolerate it and get the most benefit. The other question is, well, once a patient has a lower burden of disease, do we think that they should be getting docetaxel? I do not see any direct evidence that there is any benefit seen in those patients when we look at the results of CHARTED and GTUG and the patients who had low burden disease. Whereas when we look at the abiraterone studies, we are seeing a benefit in those patients. So I think it's fine to justify and use abiraterone more than docetaxel in patients with low burden disease. Then how about a patient who now has castration-resistant disease? The treatment options depend on what treatment they had for hormone-sensitive disease. And so if a patient has a good response to abiraterone, then they could possibly be treated with enzalutamide after progression, or they could be treated with chemotherapy. But also, if you can access radium, it is also a reasonable option if they have bone-only disease. And then think about chemotherapy with docetaxel or cabazitaxel. The big question is to think through which drug and when for the right patient, and it's looking at, are they fit for chemotherapy again, what treatments they've had before, how well did they respond, how well did they tolerate it to make the decision. I think it's like playing chess, where we try to get as many of the chess pieces on the table, and the chess pieces are radium before they have metastatic disease in the liver or large lymph nodes, but bone-only disease. Docetaxel and then cabazitaxel are two other chess pieces, and the hormones are another chess piece. And it's all about trying to move the right one. Sometimes you need to move the chemotherapy because they have poorly hormone-sensitive disease and they need chemotherapy, or they've had all the hormones. So there's no one right sequence. It's trying to get in the most number of treatments that make the most sense for the patient based on what they can tolerate and what treatments they've had before. I thank you for taking the time of watching this video.